and principle of nutrition in the ICU. Our speaker for today's very important topic is Dr. Yogesh. Yogesh sir is a chairperson of Indian Society of Chhatrapati. He is a senior consultant head of the critical care department. He's internal medicine as well as surgical medicine. So, and he is also a active member of ISKCON Society. He's a chairperson from the ISKCON Nutrition Society. And I can see that he is very active in the other social activities like Lion Club Healers, the How Gaon Chale, lot of activities he is doing. I think none other than Dr. Yogesh would be a right person to talk on this important topic. So without much wasting the time, I think Dr. Yogesh sir, please cover the topic.
Hello. Yes. Thank you, Dr. Thank you, Dr. Swarna Deepak. It's welcome all the participants. This is very important topic, nutrition assessment and principle of nutrition in ICU. Learning objectives to recognize nutrition risk in ICU, then apply Nutric score for triage and nutrition of the patients in the ICU. Prescribe the energy and protein requirements safely to the patient, then choose enteral nutrition versus parenteral nutrition and various formulas for the patients, prevent, monitor and complications of the nutrition, then manage special populations. Why ICU nutrition matters? Critical illness per se, it is a hypermetabolic or catabolic state. That's why the energy requirement, protein requirement may be variable in each patient. So you have to formulate differently for each patient. Malnutrition that increases chances of infection, then wound healing can be poor. That's why meticulously you have to plan nutrition for your patient. And nurses also, that will be very important as playing important part to plan the nutrition along with the doctors and dietitians. Then prolonged ventilation and ICU stay can be there, and then again you will be planning nutrition meticulously. The for nutrition, it may increase the morbidity, mortality and cost of the patient when patient is in the ICU. That's why you need to plan it meticulously, and nutrition matters a lot for the better outcome of the patient. Then pathophysiology of critical illness, stress hormones and cytokines that play, and enormous proteolysis happens there. That's why protein nutrition that will matter a lot. Then insulin resistance can be there and hyperglycemia can be there. Then you'll be planning that, or you'll be managing that hyperglycemia in the ICU tightly. Mitochondrial dysfunction, micronutrition drain that may happen, and then you will be planning the way that refeeding syndrome or some complications of the nutrition will not happen. That will be seen in the next slides. Then negative nitrogen balance, that will again predict the poor outcome of the patient, and that you will have to maintain the protein part of the nutrition. Consequences of malnutrition, we can see that immune dysfunction may happen, then pressure injuries can happen, sarcopenia will happen, then ICU acquired weakness can be there, which can prolong the stay of patient in the ICU. Failed weaning, deconditioning, that will again increase the mortality in the ICU. Then delayed recovery could be there. Again, that will increase the cost of stay to the patient. That's why nutrition matters a lot in the ICU, along with the other therapies that we are planning for the patient. Screening versus assessment. Screening is usually fast, like NRS 2002 score that we can use for screening. Then assessment can be a detailed clinical examination, then lab parameters, then tools, then Nutric score. That is the assessment of the nutrition in the patient with clinical judgment. That will matter a lot for the outcome of the patient. Most commonly, the Nutric score that is used in the various ICUs to have the same validity in all the ICUs. Only ICU specific nutrition score, it is identifies who benefits from the aggressive feeding. It is validated across the ICUs. That's why most commonly used in all the ICUs across the world, and we can validate it. Then we can see from this table that what are the components of the Nutric score. Age, like various points are given for the age, like less than 50 0, 50 to 75 1, then more than 75 2. Then Apache score is part of the Nutric score. Then SOFA score, which we usually apply in the ICU, that is also one of the component for deriving the Nutric score. Number of comorbidities, like we can see that 0 to 1 it is 0. Then more than two comorbidities, we'll be giving a score of 1, and we'll be adding that. Then days from the hospital to ICU admissions, that is more than 1 day, that will be giving 1 point for that. Then IL-6 may be there in use or may not be there use when it is not available. When it is more than 400, then we'll be giving 1 point for this. And from the down table we can see that some of the points, like 6 to 10, it is a high score. It is associated with worse clinical outcome, mortality, as well as the ventilation requirement. These patients are the most likely benefit from the aggressive management of the nutrition therapy. Then 0 to 5, it is a low score. These patients have low malnutrition risk. The nutric acid scoring system, if no IL-6 is available, again the 5 to 9 is a high score, 0 to 4 is a low score. Again the same explanatory part for this, associate 5 to 9 associated with worse clinical outcome. Mortality, high mortality would be there. These patients are these patients are the most likely benefit from the aggressive nutrition therapy. Then 0 to 4 score, these patients have low malnutrition risk. Then you will have to plan accordingly. Nutrix components, as we have seen in the table, age, Apache to score, SOFA scores we are using. Comorbidities more than 1. Day of hospital, that we have seen that more than 1 day of hospital, then you will have to plan the nutrition aggressively. Then optional is IL-6. Nutrient scoring and interpretation, 0 to 1, that we have seen that it is a low risk, 5 to 9 it is a high risk. And in the high risk patients, prioritize timely protein and energy nutrition, that will matter a lot. Compute this score on admission, recheck as when it is needed again to be calculated. Using Nutric in practice, calculate Nutric, classify the risk. The high risk patient, start enteral nutrition early, escalate to the targets for the better outcome. Low risk patients, conservative start can be there. Then watch for the tolerance, and consider supplemental parenteral nutrition if goals are unmet. That is the one of the important aspect for the ICU nutrition. Nutric score limitations, it needs Apache to score and SOFA scores. That detailed scoring is needed for Nutric score calculation. Then it complements it. It does not replace the clinical judgment for patients. That's why individual planning of the nutrition for each patient, that is very important. Clinical assessment, we have seen that clinical assessment is a very important part. History is again very important. Weight loss, then intake, number of comorbidities that you have to assess, and what will be the outcome of patient, that you can judge from the clinical assessment. Then examine muscle fat loss, sarcopenia, that you can examine. Edema, ascites, sores are there. Again, that will be the indication of malnutrition. Then fluid shifts, that confounds with the weight and BMI. That's why weight and BMI, that singly will not carry the weightage for the for planning the nutrition for individual patient. Functional clues like winning and mobility, this functional part, that will matter a lot, that will be seen in the subsequent slides. Apart from the Nutric score and clinical judgment that we have for planning the nutrition in each patient. Anthropometry, weight, BMI unreliable with fluid loading. Many of the patients that are like edema is there, then these measurements will be you cannot do these measurements. Then mid upper arm circumference skin fold limited acutely. Use trains in the long stay patients. The trains will that will matter a lot. Biochemical markers, albumin, pre-albumin, transferrin. These are the biochemical markers we use in the ICUs, but those are mainly the inflammatory markers and not nutrition per se. That's why they will have the limited for planning of the nutrition in a patient. Then CRP contextualizes low visceral proteins. Triglycerides you can measure, lipids, then urea creatinine, LFTs. This will be like of some help to the doctor and the dietitians for planning the nutrition for individual. Functional nutritional assessment, this is one of the important part apart from the anthropometric measures, and then the various score systems. These are used in the ICUs. Traditional nutrition assessment is equal to weight, body mass index, albumin, etc. But in critical illness, weight distorted by the fluids. Lab reflects inflammation and not nutrition. That's why functional measures is equal to direct assessment of the physiological and physical performance linked to the nutrition status. That's why these functional parameters will matter a lot in the ICU while determining the nutrition to a particular patient. Domains of functional nutrition, we can see muscle function, then immune function, cognitive function, wound healing and recovery. Muscle function test, hand grip strengths, that is routinely practiced in the ICU. Simple bedside test with dynamometer correlates with protein energy malnutrition, and it will predict the outcomes. Then ICU length of stay. Then 6-minute walk test used in subacute or rehabilitation phase. This is one of the good tests. Then respiratory muscle strength, maximal inspiratory pressure, important for ventilator weaning. This parameter can be used. Immune functions, these are like delayed cutaneous hypersensitivity test. It is limited use now. Total lymphocyte count, crude and non-specific. Research markers like various biochemical markers, cytokine profiles, neutrophil functions. But mostly immune function, or these will be a research oriented tools, and practicability can be less as compared to the other functional parameters we use in the ICU. Functional recovery indicators, time to extubation. Nutrition is equal to the respiratory muscle strength, and that will facilitate the extubation in a patient, and that can denote that the particular patient is nourished and extubation is possible. That can be judged with the clinical assessment. Then wound healing, then pressure sore recovery, you can watch all these parameters clinically. The return to baseline activities of daily living, when patient is doing the daily baseline activities, so that you can assess that the nutrition supplemented is sufficing the needs of the patients, and the recovery would be good. Body composition and muscle mass, various ultrasound is there now, that is used routinely in the ICU. You can analyze the muscle thickness of quadriceps, biceps muscle, cross sectional areas where the expertise is available. In CT, MRI, those are also used in the assessing the muscle mass. But mostly practicability of all these investigations or all these technological gadgets, it will be limited in while using in day-to-day ICU practice. Then bioelectrical impedance analysis, that is a predictor of survival. Then DEXA scan, again impractical in the ICU. That can be a research tool when you are planning any study, or that time the technology will be helping out significantly. Practical use in the ICU in day-to-day patient care. At admission, you can have your Nutric score. Then subjective assessment, you can have muscle ultrasound and hand grip, that can be practiced regularly. During stay, monitor muscle thickness, grip strength. Then in recovery, 6-minute walk test, then activity of daily living scores, that can be applied in the recovery and rehabilitation outcomes you can measure. Advantages of the functional assessment. Functional assessment is always a better way to assess the recovery or winning of the patients from the ventilator. Functional nutrition assessment, that is equal to measuring the performance, not just the numbers, because that will matter the recovery of the patient. Then strongly predicts outcome like winning, then length of stay in the ICU, then mortality. Should complement traditional nutrition scores. Uh, Practical bedside tools, hand grip strength, muscle ultrasound that can be easily applied in day-to-day ICU practice. Indirect calorimetry. This is per se gold standard for energy expenditure, where oxygen consumption and release of the CO2 that is measured for the giving the value of the caloric requirement of the patient. Use of indirect calorimetry when it is available, and repeat when condition changes. It can be repeated according to the clinical judgment. Again, the clinical judgment will matter a lot in using any parameter for nutritional assessment in a patient. Then when indirect calorimetry is not available, then predictive equations like from the mathematical calculations you can apply in day-to-day practice of ICU, like 25 to 30 kilocalorie per kg per day in general ICU target. Adjust for obesity, burns, sepsis. It will differ according to the it will be individualized. Avoid overfeeding early. These are the basic principles for planning the nutrition. We have seen the nutrition assessment part, and now various principles will be seeing. Then energy targets, like start with the hypocaloric, like 15 to 20 kilocalorie per kg per day. If like there is a high risk of refeeding syndrome, you can follow the nice guidelines. Then when BMI is really low, like less than 18, then definitely you will be going slow. Then advance to 25 to 30 kilocalorie per kg per day over 48 to 72 hours. Monitor glucose, then CO2 production, then triglycerides. Then that you can modulate the nutrition of a particular patient's. Protein targets, as we know that 1.2 to 2 gram per kg per day is typical ICU protein requirement. In burns, major trauma, up to 2.5 gram, that you would be escalating the protein for these patients high, as it is a high catabolic state. Prioritize protein even if hypocaloric nutrition is started earliest. Protein prioritization is very important aspect, principle of that. That is a very important principle in the ICU nutrition or formulating the nutrition for a patient. Then protein in renal failure, AKI, patient is not on RRT, then 0.8 to 1 gram per kg per day. You will be restricting protein slightly. Intermittent hemodialysis patient, you can keep the protein in the range of 1.5 to 2 gram per kg per day. When patient is in CRRT, up to 2.5 gram per kg per day of protein requirement can be formulated for that patient, considering the losses. Protein in liver failure, 1.2 to 1.5 gram per kg per day. Just avoid the reflex restriction of protein in each and every patient of liver failure. Consider branch chain amino acid enriched if encephalopathy is there. Sodium moderation will play an important role in the treatment of these patients. Carbohydrate and glycemic targets, we know that 50 to 60% of the energy that will be derived from the carbohydrate, that is non-protein calories. Then glucose, that will infusion rate would be 4.4 to 5 milligram per kg per minute, and target of the blood glucose levels that you will be maintaining will be 140 to 180 milligram percent in the ICU. Lipids, 20 to 30% of total calories will be derived from the lipids. Prefer mixed emulsions. Avoid excess lipids in ARDS or sepsis patients. Monitor triglyceride levels regularly, and hold triglycerides if it is levels are more than 400 to 500 milligram percent. Micronutrients play important role along with the macronutrients. Vitamin A, C, D, E, zinc, and selenium commonly used, and the levels can be low. Replete the nutrients earlier because they play role in various biochemical reactions in the body. Consider stress dosing in the burns and trauma. Check levels if prolonged ICU stay, and that will help you planning the micronutrients along with the macronutrients in the ICU. Then some syndromes are very important, and knowing the pathology of these syndromes, like while starting nutrition in a malnourished patient, refeeding syndrome, every clinician has to know, and along with the dietitians, along with the nursing, it is a insulin surge, and that leads to intracellular shift of phosphorus, potassium, magnesium, and this is one of the deadliest complications of feeding a patient. And like high risk patient, definitely one will have to be very precautious while starting the nutrition, and hypocaloric nutrition will matter here. Arrhythmia can occur, respiratory failure is there, delirium is there, uh, because of thiamine depletion, lactic acidosis is there, and the mortality is very high. That's why one has to be very precautious when starting a nutrition in malnourished patient. Then prevention protocol: identify the risk, low BMI, weight loss, starvation. Then start thiamine 100 to 200 milligram before and with feeds. That will play very important role. Start 10 to 20 kilocalorie per kg per day. Advance slowly. That slowly advancement is very important. Check phosphorus, magnesium, potassium 6 to 12 hours initially, because they play a important role, and you have to supplement with all these micronutrients in the early phase as well. Enteral nutrition initiation and advancement: start 10 to 25 ml 25 ml per hour, increase 6 to 12 hourly. Goal that is by 48 to 72 hours you can judge it, that whether you have to escalate the enteral nutrition. You may use the post pyloric for high aspiration risk patients. Such tubings you have to select while planning the nutrition, and according to the requirement of the patient, or if there is a intolerance is also there, will have to judge that clinically. Enteral nutrition intolerance recognition is very important. High gastric residual volume, vomiting can be there, distension of abdomen can be there clinically, then diarrhea can be there, more than 3 loose stools per time will be there. Strategy: slow the rate, dilute it, use prokinetics, change the formula. Use local GRV thresholds and policies. Whatever you practice in your ICU, that will matter. Then aspiration prevention bundle, that is head of bed has to be at 30 to 45 degree. Verify tube position. Post pyloric if recurrent, it is recurrent. Then oral care, minimize the sedation, use of prokinetics, that will matter. Tube choices, these are the various tubes available, like normally used nasogastric, easier, and gastric tubes we routinely follow. Then nasojejunal, then various other for long-term nutrition, like percutaneous enterogastrostomy or jejunostomy, that can be done in particular cases like pancreatitis, or any surgical patients where the you need to bypass the gastric thing. Then formula basics: polymeric, that is standard protein, intact protein, that we use commonly. Then there can be peptide or oligomeric proteins that will be helpful in the malabsorption. Then amino acid based formulas in very severe malabsorption or allergy, that will be help. Add fiber wherever it is appropriate. Then system specific nutrition, that will matter a lot. Pulmonary and ARDS or COPD patients, lower carbohydrate, higher fat, then that will lead to decreased CO2 production. Then omega 3 fatty acids for inflammation modulation that can be used. Usual targets 25 to 30 kilocalorie per kg, and proteins 1.2 to 2 gram per kg that we have seen. Then renal, one has to be cautious with the protein. Then electrolyte restricted formulas. In dialysis patients, higher protein needs can be there. Concentrated fluids to limit the fluid limit, that will be planned. Then CRRT, consider a higher protein in CRRT patients that we have seen. In hepatic nutrition, hepatic failure, we have seen already this 25 to 30 kilocalorie per kg. Then protein can be given 1.2 to 1.5 gram per kg. Then branch chain amino acids that can be supplemented and restrict the sodium. This we have seen. Then diabetes and stress hyperglycemia. Lower the carbohydrates, higher fatty acids, fiber is important, that plays important role here. Basal bolus insulin targeting the sugar levels to 140 to 180 milligram percent. Avoid overfeeding of carbohydrates. In obesity, when BMI is more than 30, hypocaloric high protein feeding that will matter. Then 11 to 14 kilocalorie per kg of actual body weight, or 22 to 25 kilocalorie per kg of ideal body weight that you can formulate for obese patient. Then protein requirement can be 2 to 2.5 gram per kg of ideal body weight. Severe pancreatitis, like you can place the post pyloric enteral nutrition that is preferred. Peptide elemental formula that will help if malabsorption is there. Parenteral nutrition only if enteral nutrition is not feasible, then you will have to consider parenteral nutrition. Then sepsis and ARDS, start enteral nutrition when hemodynamically stable. Avoid early overfeeding. Nutrition, mixed evidence is there with the immunonutrition, like glutamine and other. Trauma and burns, like the protein requirement will be specifically higher, then we'll have to escalate that requirement. Antioxidants, trace elements, consider omega 3 fatty acid, arginine, glutamine in select cases. Surgical ICU pulse, enhance recovery synergy with the early enteral nutrition. Anastomosis, jejunal feeding often feasible. Monitor ileus, this is one of the common, like with hypokalemia that can happen in the ICU. Avoid narcotic heavy regimens. Always these all pillars that will be playing in the ICU for the better outcome of the patients. Then parenteral nutrition indications. We have seen that whenever there is a contraindication for the enteral nutrition or failed enteral nutrition, like intolerance of the enteral nutrition, then you go for the parenteral nutrition. Persistent intolerance, the high output fistula, as a supplement when enteral nutrition less than 60% of the needs after several days, that can be supplemental form. Then parenteral nutrition composition, amino acid, dextrose, lipid, electrolytes, vitamins, trace elements daily. Individualize glucose and lipid split, add insulin as needed. Parenteral nutrition complications and prevention. As we are seeing these principles of the nutrition therapy, you have to know the specific indications, contraindications. Catheter infection that has been found, then you have to follow the strict asepsis while formulating the parenteral nutrition. Hyperglycemia can be there, electrolyte shift can be there. You'll have to keep a tight watch on all these serum levels. Then fatty acid hypertriglyceridemia can be there. Avoid overfeeding. Cycle parenteral nutrition, that will matter a lot. Combine enteral and parenteral nutrition. High risk, high nutric score patient, and they are not meeting the goals with the enteral nutrition only, you can add parenteral nutrition. Wean parenteral nutrition as enteral nutrition reaches 60 to 80% of the needs. That you can see that way. Timing, when to start or delay. Start enteral nutrition 24 to 48 hours if patient is stable hemodynamically. Delay the enteral nutrition in uncontrolled shock, ischemia, severe acidosis, abdominal compartment syndrome. Monitoring schedule, daily vitals, then tolerance for the feed, the stool and fluid status of the patient that you will have to monitor. labs, glucose electrolytes. We have seen in the high risk patients for the refeeding syndrome, phosphorus, magnesium, potassium, that will have to be monitored along with the LFTs and kidney function tests and triglycerides. Micronutrients can be monitored weekly. Now, blenderized versus the commercial versus peptide comparison. Blenderization is cheap and natural, but contamination risk can be there. Always use of freshly prepared blenderized formulas so that contamination risk will be less. Commercial polymeric, sterile and standardized, cost will be the important factor here. Then peptide and amino based amino acid for malabsorption, short gut, no routine mortality benefit has been seen in the trials. Selective use only. Resource limited ICU tips, safe blenderized feed with strict hygiene and micronutrients add-ons that will suffice the nutrition of the patient. Concentrated formula for fluid limits. Prioritize protein always. Use checklist and track the delivery. Always make a checklist in the ICUs while formulating a nutrition to a patient. Daily ICU nutrition checklist that matters. Nutric score as and when required you can calculate. Then enteral nutrition, the goal is achieved or you need to escalate, or that you'll have to see whether patient is tolerating your enteral nutrition, that you will have to watch. Strict clinical vigilance will be very important. Glycemic control will matter a lot. Monitoring the phosphorus, magnesium, potassium level, and then thiamine to be given at the early phase, that will be part of your checklist. You will be maintaining this checklist strictly. Then triglyceride LFTs if on parenteral nutrition. Documentation and quality metrics, percentage of the goal of calories protein delivered. Enteral nutrition interruption time. Then aspiration events also document. Parenteral nutrition catheter days, that will matter. Infection you will have to observe clinically. Then weight train, functional milestones, that will play the important part that you will be assessing in day-to-day clinical rounds. Common pitfalls that can happen in the ICU. Overfeeding early phase, that we see commonly in the ICU. Unnecessary protein restrictions in the liver disease, that we have seen. Delayed switch to post pyloric when needed, that is also seen. And ignoring the refeeding risk. Refeeding syndrome can happen there when you ignore the high risk patients, and that is a deadly syndrome, and everyone has to be aware of this. So these are the when you common pitfalls everyone has to by heart and know in the ICU, so that properly nutrition will be formulated for a patient. Take home messages: start enteral nutrition within the 24 to 48 hours if feasible. Protein first, that is 1.2 to 2 gram per kg, higher in case of burns, CRRT. Avoid overfeeding, monitor closely, tailor formula to organ function. Then enteral nutrition versus parenteral nutrition, as we have seen that when hemodynamic stability is not there, then resuscitate first. If it is there, then go for the enteral nutrition and escalate according to the need of the patient and daily monitoring. Post pyloric, as we have seen, that can be used if less than 60% of goal is achieved by day 3 to day 7. You can add parenteral nutrition, and winning of the parenteral nutrition as the enteral nutrition needs are achieved, like more than 60 to 80% patient is taking, then you can win from the parenteral nutrition. We can now see a few of the case scenarios for the nursing students. Now, case one, these are the formulated cases. 65-year old male, weight 70 kg, weight loss 8 kg during the last 3 months. Apache scores 28 so far, 10. This is a Nutric score is very high. Lactate is settling. Norepinephrine is low dose. These are the two important parameters, those assessed clinically again. Then what will be the plan for this patient? start the enteral nutrition at 20 ml per hour. Prokinetic can be used. Advanced calories to the 1800 to 2100 kilocalories per day, that is 25 to 30 kilocalories per kg. As weight is there, there is no need to go for the initially slightly hypocaloric, then advance the calories. Protein goal, as per the standard protein goal would be there at 0.5 to 2 gram per kg. That will come to 105 to 1 gram per day for this patient. Then blood glucose, that will be monitored, electrolytes will be monitored, and if parenteral nutrition can be added if the enteral nutrition goal, that is more than 60%, that is not achieved by the day 3. Second case, we can like the formulation of the nutrition, the AKI on CRRT, a 58-year-old female, weight 60 kg, septic AKI on CRRT, diarrhea, here diarrhea is there with polymeric feed. Then what will be the plan for this patient? You can switch to peptide formula. You can use the post-pyloric tubings. Then energy requirement, as patient is on the CRRT, it can be like 25 to 30 kilocalorie per kg. That will come to around 1500 to 1800 kilocalorie. Then protein requirement, you can formulate to 2.2 to 2.5 gram kg, as patient is on the high losses of the protein is anticipated, as patient is on the CRRT. That will come to 130 to 150 gram. Then monitor phosphate level, magnesium, potassium, adjust electrolytes in the feed. Case 3, we can see that it is a obese COPD on NIV. The weight of the patient is 120. Ideal body weight is 70 kilogram male. COPD with exacerbation. Hypercapnia is there. Difficult weaning is there. What will be the nutrition plan in such patient? Then hypocaloric, then high protein, 11 to 14 kilocalorie per kg, the actual body weight, that will come to 1300 to 1700 kilocalories. Protein requirement, that will come to 2 to 2.5 gram per kg of ideal body weight. That will be around 140 to 170 gram. Then pulmonary formula, lower carbohydrate, that will be planning for this patient. Then tight fluid balance will be for this patient. So this way we can see that individualization of the nutrition for each patient, that will matter a lot, and that will improve the outcome of the patients, and that will reduce the mortality. The appropriate timing of the starting nutrition, then shifting to parenteral nutrition, or continuing with the enteral and parenteral both nutrition, then assessing the intolerance to feed, that will simultaneously you will have to look. Then supplementation of the micronutrition, that will matter a lot, and you have to be vigilant while planning a nutrition to a critically ill patient, and that will save more life, and that will reduce the mortality, that will reduce the length of stay in the ICU, that will reduce the cost of the ICU in that patient. Thank you very much. Dr. Swarna Deepak.
Yeah, Yogesh sir, thank you so much. It's a quite an elaborate and exhaustive lecture. I think we have covered most of the salient points. Quite impressive that you covered both the initial, how to approach it, what are the scores to actually do the initial part, as well as the students needs to understand that you need to have a both functional assessment as well as a structural assessment, both of them. You can use the newer gadgets as well, like an ultrasound, bioimpedance. And it's always a dynamic thing, the nutrition assessment. It's a therapeutic nutrition. And over a period of time, you should remember about the calorie debt also. Most of the times, we'll be shifting the patients to CT scans, some procedures. Most of the time, we'll be keeping them in nil by mouth. So all these things play a huge role in the depriving the patients of the proteins. And the special settings, like Yogesh sir has told, like patients who are on NIV, COPD patients, renal failure patients, try to have a logical thinking. Don't deprive them of the protein unless until it is absolutely required. And these patients also develop over a period of time. The patient initial day will not be the same requirement as the convalescent period. So as long as you have this in mind, I think it should be a good one to have it. So Deepa, if there's any questions from the students, please let us know. Deepa, you're there?
Yes, sir.
Yeah. Any questions, Deepa? You are not audible.
No, sir, there is not any question in the chat box.
Okay. Fine. Then I think we'll be closing the session. Yogesh sir, thank you so much for the lecture. In fact, I also learned many new points. And I think this lecture will be easily available for the students both on the ICSM channels, YouTube and the Facebook, as well as their other modalities as well. So kindly reach out to both of us if there's any further clarifications.